My topic today, hopefully I will make it short, but it's interesting because you have to search throughout the literature with a magnifying lens to find robust data that can guide us to the right decision with a very complicated patient population. And it is required the intelligence of the smartest people to solve this issue, and we still do not have an answer. So I will try to go through what we have in the literature. And I'm glad that our surgical colleagues are here who can verify some of the finds. I'm going to talk about functional mitral regurgitation in dilated cardiomyopathy, not ischemic, medical versus surgical options. Now, we've learned, contrary to what we knew back in medical school, that the mitral valve is not just a structure that is interposed between the left atrium and the left ventricle. It is a complex apparatus, and it is basically made up of multiple structures, all interconnected, very dynamic, that starts from the left atrial wall, annulus, leaflets, chordae, papillary muscles, and the ventricular walls themselves. All of these work together in concert to create a competent valve for basically the pump of the heart, and this made it a complex structure. The cardiac fibrous skeleton plays a major role in the competency of this valve. We know that the mitral annulus is fixed by the cardiac skeleton, which is deficient posteriorly, which allows it to act like a sphincter, and also allows it to dilate should the left atrium or the left ventricle dilate to accommodate the stretch in the wall. The annulus itself is very complicated and an amazing structure. With more imaging, we learn to know that it is a three-dimensional structure, not planar, and it has two diameters, the intercommissural and the septolateral diameter. Also, it has a height, and that height is basically will play a major role, as we will see. This gives it a saddle shape that it was found it decreases the stress on the leaflets, which plays a major role in alleviating MR in the early phases. The annulus, as I said, acts like a sphincter. It dilates during diastole to allow for better LV filling, and it constricts during systole, which allows for mitral competency. The three-dimensional shape of the annulus also changes. It gains more height during early systole, becomes more saddle-shaped. So it's a dynamic structure, and that function needs to be retained to maintain a competent valve. So functional or secondary MR in dilated left ventricles is basically a situation where the leaflets are fine and the chordae are fine. The problem is in the ventricle. And the ventricle, as it dilates the annulus, and this gives us the functional MR. Of course, regional wall motion abnormality can cause functional MR, such as in ischemic ventricles. Chronic RV pacing, left bundle, can give you a dysfunctional papillary muscles and remodeled ventricle that leads to dilation. So functional MR is a ventricular problem. It is not a valvular problem in its essence. So in a functional MR, the four problems are the dilated annulus and the reduced annular systolic constriction, which is part of the dysfunction of the ventricle, apical and lateral displacement of the papillary muscles, which tethers the chordae and therefore the leaflets, and reduces the reduction in the transmitral pressure gradient, which is normally the closing force for the leaflets. The Carpentier devised his classification for MR that was mainly capturing primary MR, but in dilated ventricles, we are dealing with two issues. It's type 1 and type 3B. There's dilated annulus. At the same time, there is restricted motion of the leaflets because of this apical displacement of the papillary muscles. In dilated cardiomyopathy, the leaflets are under a lot of strain. They're being pulled by the annulus from one side and by the papillary muscles from the other side, which creates what we call tenting, which is noted on echo very well, and that restricts the motion and limits the coaptation. So as is mentioned in the 2014 guidelines from ACC and AHA concerning the secondary MR, it is a ventricular problem more than a valvular problem. Therefore, restoration of the mitral valve competency by itself does not cure the problem, and we don't have evidence as to what's the best way to approach this. The secondary MR is staged like all the other valvulopathies, and it is of note that the effective regurgitant orifice in secondary MR is half primary MR for severe MR. So an ERO of 0.2 indicates severe MR, and that has been linked to outcomes. So the outcomes of 0.2 ERO equivalent to the outcomes of a primary MR with an ERO of 0.4. Now, to treat secondary MR, and again, most of the literature does not separate when devising a trial or a study between within functional MR as ischemic and non-ischemic. They're all bundled together, so it's hard to really separate the data. But in treating secondary MR, of course, our options include medical therapy, electrical therapy with devices, surgery, which has 4 arms: mitral valve replacement, repair, LVADs, and transplant. And recently, we have been given the option to have percutaneous therapy, and we'll talk about that. First approach was, and this was before even we have all the data, the establishment of oral therapy for heart failure, is restrictive mitral annuloplasty. And this was pioneered by Dr. Bowling from Ann Arbor, Michigan. And at the time when they were doing CABG for patients, they would put mitral a restrictive annuloplasty ring, and it was a low-risk procedure, not time-consuming, and it was even offered for dilated cardiomyopathy, non-ischemic. Over time, these rings have developed to be cause-specific, and as Dr. Bono described in his paper, there are rings that are used for functional MR, ischemic, non-ischemic. No real data behind this, but this is what the surgeons have been using. Some have elected to use rigid rings, some have elected to use flexible rings, 3-dimensional rings, planar rings, but no robust data behind any ring. There are 2 problems with the rings. One is that it does not offer mortality benefit. This retrospective data, large series, over 5 years, patients, similar characteristics were not randomized, but some got the annulus, restrictive annular repair, and some got just the medical therapy, and there was no mortality benefit after 5 years. The other problem is recurrence in significant MR. +3, +4 MR occurred in around 30% within 2 years. So clearly, annuloplasty is not the ultimate solution for this kind of problem. It is a complicated problem and probably requires a complicated solution. A simple solution probably is not going to be the answer. So with these results, people went back to study these valves before they repair them to see what valves can benefit from repair. And imaging, especially echo, provided a lot of information. And these are the mitral valve deformation measures that are used to predict which valves will benefit, which valves will have recurrence of MR. And it's been established that these parameters can predict which valves will be regurgitant and will fail. Most of them clearly describe the ventricle itself. We'll stop here talking about surgery. We'll come back to it. But at this point, do we have any guidance in managing the functional MR? The ACC/AHA most recent guideline 2014 give a class 1 indication for, of course, heart failure therapy, because this is again a ventricular problem. It is not a valvular problem. So as Dr. Al-Habib mentioned, we have to use the ACE inhibitors, ARBs, the evidence-based beta blockers, spironolactone, or all these medication have to be used to try and help the ventricle unload it, help it to reverse remodel, block all these neurohormones, and hope that this will improve the ventricle and eventually improve the regurgitation. They're not given to fix the mitral valve, they're given to fix the ventricle. Also given a class 1 is electrical therapy with CRT, or resynchronization of the ventricles. Unfortunately, not all patients are candidates for this therapy, and not all patients who receive this therapy are responders. Nevertheless, there are acute improvements in MR and long-term improvements in MR with CRT that has been documented. As far as surgery, and there is sort of an agreement across between the two continents as far as surgery for these secondary MR. We don't have much evidence. If you look at the level of evidence, they're all level C, surgery has not been shown to improve mortality or have a durable symptomatic relief. So class 2A was given to patients going for CABG or going for AVR, to if the patient has severe MR and symptomatic, to maybe put a ring or do some kind of repair. And if the patient is severely symptomatic, despite optimal medical therapy and CRT, and not going for surgery, gets a class 2B. So it's very difficult to convince a patient to go in with no other reason for surgery except to go and fix the valve when the ventricle is severely, dysfunctional, and the patient on optimal medical therapy. So a concept has emerged, just like in the revascularization literature, which is reverse remodeling viability. And this comes really from the surgical literature. Basically, a ventricle that has crossed the point of no return cannot remodel. And so operating on the mitral valve will not help. So we need to figure out which ventricles can remodel. And the surgeons started to select their patients more carefully before taking them to the OR. So there's a preoperative risk, and to choose which patients. As far as the reverse remodeling viability assessment, again, there are no data, but these are expert opinions. Which ventricles can remodel? MRI provides great insight into that. Now, is restrictive annuloplasty enough? Now more attention is being paid to the subvalvular apparatus. More surgeons now are experimenting and doing work on the papillary muscle, such as papillary muscle approximation, papillary muscle optimization, and papillary muscle relocation, as this realigns the chordae to be perpendicular to the mitral plane, and that gives it more competency and more durable repair. Also cross-papillopexy, crossing the chordae. All these are attempts to try and approach this as not just a valvular, but also a ventricular. Now, the future of mitral valve repair, as technology advances, both imaging and the computational level, is to acquire 3D volumetric data of the entire mitral valve apparatus, and then plug it into computational models. And this will basically give us a virtual mitral valve apparatus, and also can calculate the leaflet deformation, leaflet stress. And this will provide the surgeon with a good view of the valve before he can actually operate on the patient. And an example of this is depicted here, where basically The mitral valve apparatus is basically depicted for the surgeon in 3D with a measurement of the stress on the leaflets, and on the chordae he can decide which cord to cut, which cord to lengthen, and then run a virtual surgery. And then he would see the result, what ring size, what ring shape, and that way he goes to treat this complicated problem with a good plan. Now, nothing has been shown in trials, but this is another way to approach this complicated problem. Moving on to the non-surgical, which is an interventional aspect. I know there's going to be a talk on the mitral clip, so I will just focus on the functional MR. We are all aware of the mitral clip. There has been publications. Initially, it's now FDA approved for primary MR. But for secondary MR, I'm going to focus on the Everest high risk registry, which basically is not a randomized. All the patients who have high STS score have been enrolled in this registry, and this is 1 year data for them. In those patients, as you'll see, they have high STS score of 14%, okay, and a lot of them had previous sternotomies. They're older people. The 1 year data shows, compared to a comparator group, that there is survival benefit with the clip. And these functional, most of them are functional MR, though a mixture of ischemic and non-ischemic. There is remodeling benefit also. The diastolic and systolic volumes improve. There is now the 4 year results of the Everest trial, which includes within it around 25% functional MR. And I just wanted to show you here in this subgroup analysis that if you look at the bottom, the functional MR, there was no difference between surgery and the mitral clip, whereas the degenerative MR, clearly surgery is better. The mitral clip in Europe, the 1 year results of the AXIS EU registry has been published 2 years ago. And this is basically a real-world registry of patients with severe MR, symptomatic. And if you can see, older patients, it resembles the high-risk study from Everest 2, and 3/4 of those are functional MR. Again, a mixture of ischemic and non-ischemic. But this is basically a real-world experience, and after they got the clip, MR improved significantly, and it remained +1 to +2 in the majority of patients. At 1 year, there is quality of life symptomatic improvement. For the sake of time, I'll just go quickly. Now, as far as the ACC guidelines, mitral clip is not approved for functional MR as of now. In Europe, it is used, but it has to meet the criteria, the echo criteria, and the patient be high risk for surgery. 2 trials are being conducted right now: the COAPT and the ReShape trial, to answer the question of mitral clip with functional MR. And they're underway. Basically, they're looking into, as a primary effectiveness, the recurrence of heart failure hospitalization and a safety, a composite endpoint. Now, other techniques are in the pipeline, are under investigation, that might be used in the future for patients, for example, who are inoperable, patients who are not candidate for the mitral clip. I'll go through them quickly. There are the occluder, then there are the coronary sinus cinching. There are different techniques now to ablate the mitral annulus to induce scarring and cause sort of like a restrictive annuloplasty, but without the surgery. There are percutaneous anchors that can be placed in the posterior leaflet to cinch it. This is the ablation of the annulus, percutaneous cord implantation, and even restraints for the LV placed percutaneously, and of course the percutaneous mitral valve replacement. A lot of options are being evaluated in the animal models, first in man experience. So to summarize, functional mitral regurgitation is a ventricular problem. It's complicated because patients are sick. So far, we don't have any evidence from surgery to improve survival, but I think now with the approach to look at the subvalvular apparatus, we might have different results in the future. We need randomized prospective trials conducted to answer this. The questions that need to be answered: who are the appropriate patient to go for surgery? And what is an acceptable preoperative mortality and long-term survival benefit? Does surgery alter the natural course of heart failure? Does it reduce mortality? When is the best time for surgery? And how much MR actually contributes to the symptoms? Now, as far as an approach, as of now, all what we have is to optimize medical therapy, provide CRT when appropriate, really confirm the severity of MR, define perioperative risk, estimate LV reverse remodeling viability before considering surgery, and discuss with the patient the option of surgery versus percutaneous. Percutaneous options are being evaluated, even though they are being used in Europe, and these might be an ultimate solution for those sick patients who are inoperable. Thank you very much.